So here we have a case study of a patient who's 76 years old. They're an ex-smoker. They quit quite a long time ago, but they've now presented with sort of progressive breathlessness over a 6-month period. 6 months ago they had a bit of a viral cough and possibly a viral infection, but they've really noticed that their breathing is worse in the last 6 months, finding it a little bit hard to keep up with their friends when they go walking. And so this is a typical patient presentation where spirometry in the investigation of breathlessness is going to be very useful. So here we have the spirometry values, and we have pre-bronchodilator, post-bronchodilator, and then we have the gas transfer. If we look at the pre-bronchodilator first, the first thing you notice is that, as I explained earlier, the difficulty in interpreting this test is that there are just too many numbers. The numbers are also not in a good order because they're not in the right order by which we should interpret them. So to step through this nice and slowly, the first thing that we want to look at is the ratio of the FEV1 to FVC. And you'll remember that if that ratio is 70% or greater, then it's normal, and that means there's no airflow obstruction. If it's less than 70%, there is airflow obstruction. And so here we can see that the pre-baseline result for the FEV1 to FVC ratio is 0.47. In the next column we have the lower limit for normal, where we can see for this patient it's 0.62. However, not all tests will give us a lower limit for normal, so we can assume that this is abnormal if it's less than 0.7. So this patient, based on that one number, 0.47, we know that there is airflow obstruction. So if that's really the only number we look at, we've actually got quite a lot of value out of that test. The second number to look at is the forced vital capacity, because the forced vital capacity tells us, is there airflow restriction or not? And we'll look at that as a percentage of predicted. And as we saw before, we have a lower limit for normal, but in general terms, we use 80% as the percentage of predicted to determine whether it's normal or not. And so for this case, the forced vital capacity is 95% of predicted. So the forced vital capacity is normal, so we can say that there's no ventilatory restriction. So this patient has a pure obstructive ventilatory defect. The next step is to look at the FEV1. And the FEV1 only tells us about the severity of airflow obstruction if airflow obstruction is present. And in this case, it's 59% of predicted. And so once again, normal is 80% of predicted. And so 59% of predicted is reduced. And as a guide, depending on what guidelines you look at, there's a bit of variability. So it doesn't matter so much, but in general terms, less than 50% is severe airflow obstruction, 50 to 70% is moderate airflow obstruction, and above 70% is mild airflow obstruction. So this person has a moderate degree of airflow obstruction. And so now you can start to see that despite there are lots of numbers on that page, we've only really looked at a couple of them, and it's told the whole story. We can also see that if we looked at the numbers in the order in which they came out of the computer, we could easily get confused. So important points are to remember, look for the ratio first, then look at the FEV1 only if there is airflow obstruction to determine the severity of airflow obstruction, and look at the forced vital capacity to see if there is ventilatory restriction as well. One thing we do need to remember is that if forced vital capacity is reduced, the other possible explanation for that is gas trapping. So in a patient with airflow obstruction, if their airways during expiration are closing and blocking off, the amount of air they get out might be reduced because it's trapped in their chest. So in that case, forced vital capacity can potentially be falsely reduced in the setting of gas trapping, where it's because the gas is trapped in the lung rather than small lungs, which is what a true restrictive ventilatory defect is. But once again, from the clinical history or from the clinical examination or x-ray findings, we can usually determine if that's the case. But if it's not obvious, measurement of lung volumes, which needs to be done in a respiratory lab, can assist in differentiating true ventilatory restriction from gas trapping. The next step is to look at the bronchodilator response. So once again, we have the same numbers as post-bronchodilator. And we also are given the amount of change in volume as well as the percentage change. So you can see that the FEV1 has improved by 5% or 70 mils. The forced vital capacity has improved by 3% or 80 mils. And so these are not significant because they don't reach our threshold of 12% and 200 mils. So this patient has a moderate obstructive ventilatory defect with no significant bronchodilator response. If we want to take it one step further and look at the gas transfer, and remembering that the gas transfer is a more complicated test that really has to be done in a respiratory lab. So a normal spirometer does not give us this value, but it's useful to look at, and it's useful to help explain what the underlying disease process is. The gas transfer essentially tells us about the ability for the lung to get oxygen from the air into the blood. So it's measuring the ability for oxygen to get across the alveolar capillary membrane from the alveolar air space into the blood. So if the gas transfer is reduced, that means there must be something interrupting that alveolar capillary membrane. So things that could do that are diseases of lung parenchyma, so emphysema, or thickening of the alveolar capillary membrane, such as we find in pulmonary fibrosis, or elevation of the pressure within the pulmonary capillaries, such as pulmonary hypertension. Remembering that diseases of the airway do not affect the pulmonary parenchyma. So a disease of the airway, such as chronic bronchitis or asthma, should not affect our gas transfer because it's not affecting that membrane between the air space and the capillary blood flow. So it's easy to remember because gas transfer, once again, normal is 80%. And so in this case, our gas transfer is the TLCO, which is 70%. So gas transfer is mildly reduced, and that means that there must be some disease of the pulmonary parenchyma. And in this patient, who we know is an ex-smoker, has airflow obstruction, based on that we can determine that a diagnosis of COPD can be made because the clinical findings are consistent and there is airflow obstruction confirmed on spirometry that is diagnostic of COPD. Now remember that COPD is usually a smoking-related disease that is a combination of chronic bronchitis and emphysema, and some patients may have more of one or more of the other, or some have pure emphysema or pure bronchitis, but most sit somewhere in between. We know that if the gas transfer is reduced, there must be some degree of pulmonary parenchymal disease, so that means there must be at least some degree of emphysema. So this patient has COPD, mildly reduced gas transfer, so there is some degree of emphysema. The reason this gas transfer is called TLCO is because the way it's measured is using the transfer factor of carbon monoxide. And so what we do is we get the patient to breathe in a known concentration of carbon monoxide, a concentration that's low enough not to cause problems, because obviously carbon monoxide in high concentrations is very dangerous. But a very small amount of carbon monoxide, they hold it in and then breathe it out, and we measure how much is expired. And if we know how much went in and how much came out, we know how much has been absorbed. And we know that carbon monoxide is readily absorbed across that capillary membrane between the alveolar space and the capillary space. So the amount that is absorbed tells us about the ability of the lung to get oxygen from the airspace across into the blood vessel. So that gives us a good idea as to how well that membrane is functioning, and if the amount of carbon monoxide expired, or the difference between the inspired carbon monoxide and the inspired carbon monoxide and expired carbon monoxide, if that difference is only minimal, then we know that the lung lacks the ability to absorb it. There must be some disease process going on to cause that. So based on those results, we can confirm the diagnosis of COPD. The severity of COPD can be based both on the clinical history and also the severity of airflow obstruction. So this patient would fit into maybe a moderate to mild degree of COPD. So the treatment of that, given that they're symptomatic and their main symptom is breathlessness, then most useful treatment for them will be bronchodilation. So I would start them on a long-acting bronchodilator, which will help relieve breathlessness in the setting of COPD. We know that this patient has already quit smoking a long time ago, so that's not relevant. Obviously, in patients, if the same patient was a current smoker, by far and away the most important management for that person would be smoking cessation, which is more effective and more important than any other thing that we can possibly do for people with COPD. The other important management aspect is to encourage this person to continue to exercise. And so exercise is really important for patients with COPD, and it relieves breathlessness, improves exercise tolerance, and improves quality of life. Pulmonary rehab is very helpful and very beneficial for most patients with COPD. I think that if this person is going for regular walks and exercising on their own, whether they want to go into a formal pulmonary rehab program or do their own exercise program, is both perfectly reasonable, especially given that their symptoms are relatively mild. So here we've got another case study of a patient who's 76 years old. They've smoked very heavily in the past, but have also quit 4 or 5 years ago. They've now presented with quite significant breathlessness after having had what sounds like a viral infection about 3 weeks ago. Up until that time, they certainly, on further questioning, do report that they were getting more short of breath than usual, but they've taken quite a significant reduction in their exercise tolerance, and they're now getting a little bit breathless on minimal exertion. So pulmonary function testing, including spirometry and gas transfer, is very useful in this patient. And so here we have the results. And once again, the numbers are in a different order to what we're used to. They're represented slightly differently from the first case because they've come from a different program or from a different respiratory lab. However, if we just go by exactly the same process as we did in the first case, we can interpret these results quite simply by just knowing the more important numbers to look at. So once again, the first number that we look at is the ratio of the FEV1 to FVC. And here we've got a predicted value in the first column, a pre-bronchodilator measured value in the second column, a percentage of predicted, and then we've got our post-bronchodilator results after that. So we'll start off with the pre-bronchodilator measurement of the FEV1 to FVC as a percentage is 36%. So immediately we can see that there's airflow obstruction. We could then look at the forced vital capacity to see if there's any ventilatory restriction, and we can see that that's 80%. So it's at the lower limit of normal, but it's normal. So there's no ventilatory restriction, so this patient has pure airflow obstruction. So already we can diagnose this patient as having COPD. The clinical findings and presentation are consistent, and the spirometry confirms the diagnosis. Because we have to remember that although the clinical presentation was very consistent with COPD, we can't diagnose COPD without confirming that there is airflow obstruction. We then look at the FEV1 to determine the severity of airflow obstruction. And the FEV1 in this situation is 38%. And so that is severely reduced. Below 50% is severe airflow obstruction, and below 40% is really very severe airflow obstruction. We look at the post-bronchodilator response, and there is a 7% improvement in FEV1, a 4% improvement in forced vital capacity. So neither of those represent a significant improvement. So that would suggest that there's no significant bronchodilator response. This is certainly not a presentation of asthma. This is COPD. The gas transfer, the TLCO is 48% of predicted. So once again, that is severely reduced. So this person also has severe pulmonary parenchymal disease, and most likely that's due to emphysema. There could potentially be a component of pulmonary hypertension as another possible cause for that severe reduction in gas transfer. But one way or the other, this person certainly has severe COPD. So the treatment for this person is along the similar sort of lines. That they've already quit smoking, which is the most important thing. The second most important thing would be exercise and pulmonary rehab. And so for someone who sounds like they've had a recent exacerbation and are far below their baseline, have severe abnormality on their lung function testing, I think this person would benefit from pulmonary rehab. They would also benefit from bronchodilation, and you could start with a long-acting beta agonist or a long-acting muscarinic antagonist, and if that provided some but incomplete response, you could use a dual bronchodilator or a LABA-LAMA combination. If we have a look at the clinical history of this patient came in on a inhaled corticosteroid and long-acting beta agonist, as well as a long-acting muscarinic antagonist. So I guess one question is this appropriate treatment for that patient? Certainly the LAMA and the LABA I think are appropriate treatments. The question is with regards to the inhaled corticosteroid. Inhaled corticosteroids are indicated for patients with COPD when their FEV1 is less than 50% and they also have frequent exacerbations, defined as 2 exacerbations in the last 12 months. So it'd be useful to know whether this patient, prior to their recent exacerbation, have had any other exacerbations in the last 12 months. And if they had, then they would certainly fit the criteria for using an inhaled corticosteroid. If the patient had this lung function that we can see, but they had not had any exacerbations in the last 12 months, if their presentation was more of just general breathlessness, slowly getting worse, then you could argue that the inhaled corticosteroid is not necessary. And if it's not necessary, it's better off that they don't use it most of the time, because they can have side effects such as effect on the voice. It does slightly increase risk of osteoporosis, cataract. It can cause some thinning of the skin and easy bruising. And there is evidence to suggest that it does increase the risk of pneumonia. So in patients with COPD, we always need to consider, is the inhaled corticosteroid necessary or not? So here we have another case. This is a 52-year-old lady who has presented with cough and productive of a small amount of sputum, maybe some mild shortness of breath, but the main problem is cough. They're an ex-smoker, having smoked a moderate amount, but they also quit some time ago. So spirometry is very useful in the diagnostic workup for this patient. If we have a look at the results, we'll go through the same process again. If we look at the ratio of FEV1 to FVC, we get a pre-bronchodilator baseline result of 0.61. So that means there is airflow obstruction. The forced vital capacity is 107% of predicted, so that's normal. That means that there's no airflow restriction. So this patient has a pure obstructive ventilatory defect in an ex-smoker who's presented with cough, and once again this is diagnostic of COPD. The FEV1 tells us just about the severity of airflow obstruction, and the FEV1 is 85% of predicted, which is actually normal. And so that means that this patient has mild airflow obstruction. So this is a good demonstration of a case whereby if you looked at the numbers in the order by which they come up on the test, you'd look at the FEV1 and think 85% of predicted is normal. The FVC is 107%, and that's normal as well. So you might be tricked into thinking that this spirometry is normal. So there's the importance of looking at the ratio first. And so even though the value of the FEV1 falls within the normal range, as a ratio to this patient's forced vital capacity, there is a reduction in that ratio, meaning there is airflow obstruction. So this patient has COPD. If we look at their bronchodilator response, interestingly, this patient's post-bronchodilator spirometry values have actually gone down. So all that means is that there is not a significant bronchodilator response, once again consistent with COPD. If we look at the gas transfer, the TLCO is 87% of predicted. So that means that the gas transfer is normal. So there's no disease of the pulmonary parenchyma or the pulmonary blood vessels. So this is purely an airways disease. So this patient is probably likely to have chronic bronchitis, which fits under the umbrella of COPD. And so we know there's airflow obstruction, there's definitely COPD. The presentation is more of cough, which is consistent with the presentation of chronic bronchitis. So if this patient is breathless, then sure, they may benefit from bronchodilation. But if really the cough and sputum production is the problem, then maybe chest physiotherapy and sputum clearance might be more useful for this person. So here we have another case. This time we have a 75-year-old lady who has presented with shortness of breath on exertion. Importantly, we notice that the BMI is 46, consistent with morbid obesity. Spirometry is useful in this patient because it'll help determine if there is airflow obstruction or airflow restriction to try and determine what the cause for the shortness of breath is. Once again, if we go through the same process of looking at the FEV1 to FVC ratio, here we have the pre-baseline ratio as 0.77. So this patient does not have airflow obstruction. If we look at the forced vital capacity, it's 50% of predicted. So less than 80% is abnormal. So this person has a restrictive ventilatory defect. Essentially has reduced lung volume, small lungs. So in this case, the FEV1 is completely irrelevant because there's no airflow obstruction. The severity of ventilatory restriction is found by the severity of reduction in the forced vital capacity. So 50% are predicted is consistent with a moderate restrictive ventilatory defect. If we look at the bronchodilator response, once again spirometry values have slightly reduced after bronchodilator, so we can say that there's no significant bronchodilator response. If we look at the gas transfer, this is quite interesting because the gas transfer shows that as a percentage of predicted, it's at the lower limit for normal. But if we measure the gas transfer and take into effect that the lung volume is reduced, the gas transfer comes out increased, actually becomes supranormal. So the TLCO is 79% of predicted, but the KCO is the TLCO, which is the gas transfer, taking into account that the lung volume is reduced. And the KCO is 127% of normal, so it's supranormal. So what that means is that the slight reduction in gas transfer is not due to disease of the lung parenchyma or pulmonary vessels, it's because of reduced lung volume. So this patient has a restrictive ventilatory defect with reduced lung volume, but actually no disease of the lung parenchyma itself. And so that is consistent with obesity. So it's the obesity that's caused the restricted ventilatory defect, the small lung volumes, but the lung itself is normal. Another example of this is if a patient had had a lung resection. So say a patient had had a pneumonectomy where one lung had been removed for, say, a lung cancer. Obviously their lung volume will be reduced, and they'll also have a reduced gas transfer because they have less lung surface area to be able to get the oxygen from the air into the blood. But the lung parenchyma might be normal, and so they may have a reduced TLCO, But when we take into account the reduced lung volume from having one lung removed, then the KCO will normalise. Another example you could do on yourself is tie a belt around your chest. So if you put a belt around your own chest and then do your own spirometry, you'll have a restricted ventilatory defect because your lungs will not be able to take the volume of air that they could normally take because they've got a belt around the chest. If you then measured your gas transfer would be removed, but that would be because your lung volume is reduced. If you corrected that for alveolar volume or lung volume, the KCO would normalise or go supranormal, confirming that the lung tissue itself is normal. And this is the same situation as a patient with thoracic wall deformity, such as kyphoscoliosis. And so this is another cause for ventilatory restriction or small lungs due to external causes rather than lung disease. So the key points with spirometry are to ensure the patient performs the test properly. There's a simple way to interpret the results by just going through a simple method, and that will give us whether there's airflow obstruction or restriction, which will help with the diagnosis, and then we can determine management. So spirometry tells us whether ventilatory function is normal or abnormal. If it's abnormal, there's either ventilatory obstruction or ventilatory restriction. The key practice points about interpreting spirometry is to look at the numbers in the correct order, looking at the ratio first, followed by the forced vital capacity, and the FEV1 makes interpretation really straightforward and easy. So I think the common errors in interpreting spirometry is to get put off by the number of numbers on the page and the order in which the numbers are displayed. So by going through them systematically, knowing which numbers to look at can make interpretation much simpler. When does a patient then benefit from being referred to a respiratory specialist? And I guess that varies, but some things I think about would include if the tests come back normal but the patient still has symptoms of concern, or if the underlying diagnosis is not clear. And the benefit that we have in our respiratory labs is that we can do some more detailed testing, especially of gas transfer. And that can give us some additional information to help in the diagnosis of patients with respiratory symptoms. The other situation would be if patients are not improving with treatment. So if there is not the expected response from a treatment, then it may suggest that there could be something else going on where more advanced or sometimes more invasive testing or specialised testing would be of benefit. The other thing is that as treatments and things progress and become more complicated, especially in the setting of severe COPD and also in patients with asthma, which is difficult to control, or interstitial lung disease where there are some new treatments, sometimes these patients would benefit from review by a specialist to see are there new treatments that this patient could get benefit from. Some of these treatments are highly specialised, such as antifibrotics for interstitial lung disease or biologic therapies for asthma, which are often very effective, but there are very strict criteria as to the prescribing of these, and whether a patient might fit that criteria often needs to be worked up by a specialist, and often that will be occurring through a multidisciplinary team in the hospital setting.